And welcome to Deuk Spine Institute, our live stream surgery. It is July 16, 2024. I'm Dr. Deuk Majan, CEO and founder of the Deuk Spine Institute. Our patient presents here with back pain. He's had quite a history. He's had surgery. You can see laminectomy. He's also had multiple fractures in the spine. When we look at the x-ray, you're going to see cement in all the bones. I did not do that. Somebody else did. I'm not saying it was unnecessary. It was necessary, I'm sure. But he's got kyphoplasties done. Let's take a look at that x-ray there. Henry, can you see it?
Yes, we can.
So there's L5 with cement. That's the black stuff. 4, 3, 2. There's actually some extravasation of the cement out of the tube body into the disc space at 2, 3. So it leaked out. Point is, he's not here for the fractures. We're here because he has problems with his discs and pinched nerves. He also has facet joint pain on both sides. We're going to be doing the Deuk plasma rhizotomy after this surgery, but we're going to start with the Deuk laser disc repair bilateral L3-4, left L4-5 to treat herniated disc pain and pinched nerves. Okay, let's get started. You ready, Dr. B? If you have questions, feel free to ask me. Shot? All right, there's 5, 4, 3, there's 3, 4. I'm going to be a little bit higher up. Num num.
Patients say that he's very hard at hearing, so his hearing aids are out, so we'll try our best to.
No worries. So our patient is awake for the beginning. We want his help.
And he's from Florida.
He is from Florida. Shot. All right, there's our first drop of blood. We're going to go for 3, 4. If you have questions, feel free to ask me. I'll do my best to answer them. In the meantime, I'm just going to keep working. Shot. Jordan is back today. For all the Jordan fans out there. Shot. And one thing you have to be aware of if you're doing a patient with soft bones like this patient, you have to be aware you could end up inside the bone accidentally. You don't want that. You want to be in the disc. Now the reason you can end up inside the bone accidentally is the bone is soft. Okay? And because the bone is soft, you could end up going into bone. Normally bone is hard. You won't penetrate the bone, but when the patient has osteoporosis, you can penetrate the bone with your needle, and you think you're in the disc, but you're not. So it's very important to have good diagnostic information. That's your x-ray machine. Pressure. All right. Now, a lot of doctors don't have good x-ray machines. They buy the cheap ones, and the cheap ones, you can't see that well. You can't see the spine. Shot. You can, you have a hard time seeing the details. You miss things. You don't want to miss things when you're doing spine surgery. I can tell you that right now. It's very important you have high quality equipment, and the equipment that we have at Deuk Spine is the best that there is. You cannot buy better. We invest in the best equipment because we want the best results for our patients. All right. How is he doing, doctor? I need his help now. Is he having any pain? AP?
How are you doing, my friend? You okay? He said, yeah, he's okay.
Coker.
Are you having
Good.
any back pain? Yes or no?
Shot. All right. So I need to be a little bit more medial with the 4-5. Well, actually, we're not bad. We're actually pretty good at 4-5. Shot. Any pain?
Are you having any pain, sir?
Where do you feel it?
Where's your
Shot.
pain?
AP.
In your back? He's having pain in his back.
All right. Just lay still. Now, why does the patient
Don't
need
move
to
your
be?
arms. Don't move these arms.
Why does the patient need to be awake? Because I need their help getting into the disc. There's nerves in there that are very sensitive, and we don't want to be too close to any of those nerves. I need his help to make sure I'm not too close. Shot. All right, so I want to get a little more medial. Shot. That's probably as medial as I can get. Shot. It's a little higher than I want to be. I'm literally wrapping around the facet. Shot. That's pretty damn good. Let's go to this one, and we're gonna shot. Try to get in at 3-4 as well. We're supposed to do a bilateral 3-4 disc repair along with a shot, a 4-5 left. Shot. Shot. Perfect. All right, we are in the disc. That's really nice. And AP. Jordan, I think we're off on orbit on the 4-5 just a little bit, and WAG as well. Maybe we can clean that up when we get back. Shot. All right, that looks perfect there. Position at 4-5 as well. So we'll just advance, and we're going to be ready to put him to sleep in just a moment. Very good. Thank you, Jordan. Any questions, Henry?
At this moment, no current questions. So in the meantime, would you want us to show on how people...
Well, the first thing I'd like to do is show the video on all the different causes of back pain. There's about 30 causes of back pain, folks, that are common causes of chronic back pain. We're not talking about tumors and infections. We're talking about degenerative conditions, things that are the more common causes of chronic back pain. So we're going to show you that video in a moment. But before we do that, I need to test these discs with the patient awake, and then we're going to put them to sleep, and you guys can watch the video, okay? So, are you comfortable?
How are you doing, my friend? Yeah, he said he's all right.
Good. How long have you had back pain for?
How many years back pain?
He has,
You said 3.
good. He's got 3 tears in his disc, and I think those are contributing to the back pain. How bad is that? You can see him moving around. He doesn't like that.
1 to 10.
How high is that? Scale 1 to 10.
8.
Is that where you get your pain?
Yes.
Yeah, 8 out of 10, concordant at 3-4. All right, is it better? Better?
Don't move your arms.
Yeah, the guide wire.
You're doing great.
All right. Shot. How bad is that on a scale of 1 to 10?
9.5.
10. We don't do 9.5. 10 out of 10. Is that where you get your pain? All right, good. Concordant. So basically, now we've tested the 3, 4, 4, 5 disc. They are causing his typical back pain that he gets every day. We're going to get rid of that pain now with the laser procedure. Are you ready, Jordan? We're going to start at 3-4, shot. I'm going to take the needle out, leave the guide wire. Henry, you can show our audience all the different causes of back pain that we commonly see here at Deuk Spine.
Copy that?
Num num. I'm Dr. R. Deuk with the Deuk Spine Institute, and we're going to discuss 30 causes of chronic back pain. Chronic back pain is back pain that lasts longer than 6 weeks, and there are 30 causes of chronic back pain. The most common cause is going to be a disc injury. Disc injuries such as disc herniations, disc bulges, disc ruptures, degenerative disc disease account for 86% of chronic debilitating back pain, and they are totally fixable with the proper treatment. The best treatment for disc injuries is Deuk laser disc repair. Let's take a look at the 5 lumbar discs that can be injured. The most common disc to be injured is L4-5, followed by L5-S1, then L3-4. The L1-2 and L2-3 discs are far less commonly affected. Next, we have facet joints. Facet joints are small joints located behind the discs in the back of the spine. There are 10 facet joints, each paired left and right, L1-2, L2-3, L3-4, L4-5, and L5-S1. The most common facet joints to cause chronic back pain are L4-5, followed by L5-S1, followed by L3-4, in that order. After the facet joints, which account for approximately 10% of chronic back pain, we move on to the sacroiliac joint. The sacroiliac joint accounts with the piriformis muscle for approximately 4% of chronic back pain. The sacroiliac joint is a joint located between the tailbone or sacrum and the iliac bone. There is a left and right sacroiliac joint. In this diagram, you can see the joints turning red, indicating inflammation and pain either in the left or right sacroiliac joint. These sacroiliac joint injuries and pain can be treated most effectively with the Deuk plasma rhizotomy of the SI joints offered at Deuk Spine or Deuk Joint Institute. The 4th most common cause of chronic back pain is a piriformis muscle injury. The piriformis muscle is located in the buttock, and there is a left and a right piriformis muscle. The muscle gets torn, unfortunately, when people bend the wrong way. This usually occurs in patients with orthopedic problems such as hip pain, knee pain, or back pain. By bending improperly, they put the muscle under too much stress and they tear the muscle. The torn piriformis muscle causes severe debilitating pain in the top of the buttock. There is a left and a right piriformis muscle, and this can be treated most effectively with the Deuk piriformis muscle release. This is performed percutaneously with a 4mm incision. The sciatic nerve does run through the piriformis muscle, and many patients with piriformis muscle syndrome also have sciatic pain down their legs, with pain, numbness, tingling, and weakness in the leg that's affected on the side of the piriformis muscle. Piriformis muscle can be treated with injections such as steroids, Botox, PRP, or stem cells. However, those injections always wear off and the patients end up coming back with the piriformis muscle pain that reoccurs. The most definitive treatment for permanent relief of piriformis syndrome is a piriformis muscle release. Next, injuries to the bones of the spine, such as the vertebral bodies, with trauma can cause fractures of the vertebral body. Vertebral body fracture is diagnosed with X-rays or CAT scan or MRI, and they're treated with injection of cement into the vertebral body. Looking at the vertebral bodies, the most common to be affected is L1, followed by L2, then L3, L4, and L5. The sacrum can also be fractured. Finally, the coccyx is the last cause of chronic back pain. You can see in the diagram the red coccyx at the bottom. This comes usually from an injury where the patient falls on their bottom, sustains pain at the tailbone, and this can be treated with injections of the coccyx ligament. These are the 30 most common causes of chronic debilitating back pain, the most common being the disc, causing 85% of chronic back pain, followed by the facet joint, causing 10% of the chronic back pain, followed by the piriformis muscle and sacroiliac joint, which cause 4% of chronic back pain, totaling 99% of chronic back pain, which is totally fixable and curable with the right treatment. Thank you. I'm Dr. Deuk Majin. Thanks for joining us. All right, welcome back, Stanford. That's where my son wants to go to med school. Yeah. All right. You can see from our video that there are many causes of back pain. Unfortunately, most doctors do not know any of them. And when you go to the doctor's office and say, I've got back pain, what they typically will do is order an x-ray and then give you pain pills, muscle relaxers, anti-inflammatories, and tell you to take it easy. Well, that's not the treatment that's going to fix you. Chronic back pain has very specific causes, and those causes don't go away on their own. They stay until you treat them properly, okay? Think about cancer. Cancer doesn't just go away on its own. You have to treat it and hope that it goes away with treatment. But with the Deuk Spine Institute, we have treatments that literally cure that pain from those sources. And we've been doing it for years and years and years, many years, 18, 20 years now, that I've been curing back pain and neck pain. Originally, I did the curing with fusions. Okay, we'd fuse the spine, and whether it's an ACDF, PCDF, lumbar T-lift fusion, it didn't matter. If you fuse the segments that are painful, you will get rid of the patient's back pain or neck pain. It's wonderful. However, once I started doing the laser surgery, I realized, because I was curing them as well with the laser surgery, that they didn't need a fusion. Fusion was unnecessary. However, most doctors don't know how to do our laser surgery. So they end up offering their patients the fusion, which is far worse. This patient has 2 discs that are causing his pain, and the L3-4 and the L4-5. That's what we're fixing today. He may have an L2-3 as well. I think I talked to him about it, but he wanted to wait. He wanted to wait on that one. So we're going to get rid of at least, I expect, 70% of his back pain with today's procedures. When I examined him here in clinic, I found that he had facet pain as well. Facet joint pain is pain in your facet joints. It's the second most common cause of chronic back pain. From the video, you could see that. All right, Henry, let's show the audience. We know the disc causes 87% of chronic back pain. That's what we discovered here at Deuk Spine, 87%. It is the major cause of chronic back pain in 87% of patients. Henry, let's show the audience why the disc can be so painful. What is happening in the disc that causes so much back pain?
Copy that.
Disc injuries start with an annular tear, damaged nucleus. Pulposis herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals.
Okay, great. Thanks, Henry. So you can see from our video that what's causing the back pain from the disc is actually a tear in the back wall of the disc. And that's where we are right now with this patient. We're cleaning that tear. And the way we clean it is with a laser. When you clean that tear with the laser, something amazing happens. The pain goes away. So we're not doing a discectomy here. We're not doing a laminectomy. We're not doing a fusion. We're not putting any metal. We're not putting any biologics in the patient. No implants, nothing abnormal. It's just a natural process where we are helping his body do what the body is trying to do. The body wants to clear out this right here, this junk, so that the disc will heal. As a matter of fact, the inflammation and pain that we're seeing this patient has in their disc, it is a result of the body trying to heal the damaged disc. The problem is it cannot, because this nuclear material, the blue stuff, just will not go away with inflammation. It's like you trying to lift 1,000-pound weight. Now, maybe you're a bodybuilder and you can do that, so maybe I should say 5,000-pound weight. You can't do it on your own. You can try and try and try every day. You can get blue in the face. You can huff and puff. You can do steroids. You can do everything you could possibly do, but you will never lift a 5,000-pound weight. So what do? You get some help, right? And the help comes in the form of friends coming over or whatever, and everybody does their part and everybody lifts, and next thing you know, you're lifting it. You call for help. Well, your body is calling for my help, the help of our laser surgery, when you have chronic back pain. And the good news is we can usually fix it. Now, you saw from the first video that there's more than one cause to back pain, and that's absolutely true. There is. So if you have disc pain and we fix your disc, and then you have still pain, but it's coming from something else. We need to figure out what that something else is, and we can do that usually by running some tests. So we will run tests, figure out where the pain's coming from, other than your disc, and we'll treat that source as well. We're almost done with this disc. This again is the left 3-4. You can see the end of the disc there. We've cleaned out the tear. Now we're not doing a discectomy, folks. We're doing an annular debridement. We're removing the hernia, the herniation, scar tissue and inflammatory tissue, some calcium and bone spurs, all within an abnormal part of the disc, the part of the disc that's inflamed. We're not actually doing a discectomy here. All right.
We have a question
Sure.
coming from Jay on YouTube,
Uh-huh.
asking, can herniated discs misdiagnose as OPLL?
Can herniated disc be misdiagnosed as OPLL?
Correct.
No. The actually OPLL can be misdiagnosed as a herniated disc. And it often is by doctors who don't know what they're doing. But if I suspect OPLL, I will order a CAT scan, and the CAT scan will show you OPLL. The CAT scan is the test to find OPLL. So if you're worried about having OPLL, get a CAT scan. If I'm worried about a patient having OPLL, I will order a CAT scan. All right, we are done here. Let's clean this up. The irrigation is, the suction is not on. I don't know why the suction is not on. Guys, we do the same thing every day. Let's get it right.
Suction, no irrigation, suction.
You know you have two suction lines, right? You need to have both of them on. You have one of them on. Huh?
Jordan, can you please
Scope off.
Can you check what's going on?
All right. So, Henry, let's show the audience how the Deuk laser disc repair works to eliminate the back pain from the disc when the disc is the cause of the back pain. What was the issue there? Huh? All right. You've got to be able to figure that out yourself, okay? That is part of your job. You can't not know how to solve a simple problem.
Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
All right, so you can see from the video that we're going in with the laser, endoscopically finding the tear, visualizing the tear. The tear itself is about 7 millimeters wide, and it's full of herniated disc. So by bringing the endoscope into the tear, you can see the herniated disc shot, you can see the calcium deposits, you can see the scar tissue, you can see everything that needs to be removed. And I use the endoscope to, I don't like doing that. I use the endoscope to, that's helpful, see everything that has to be cleaned out. And you can also see when you're done. So that's how this procedure works.
We have a question.
We need some light on the surface here so I can see. But I got it finally. Yeah. Shot. Come on, Jordan. I don't know where the tip is.
Coming from Ian on YouTube, asking, does insurance cover this surgery? If not, what is the average cost?
Well, Ian, it depends on your insurance whether or not it's going to cover the surgery. Everybody's insurance is different. The average cost I don't have. I don't deal with the cost information. But it is worth it, even if you have to pay out of pocket. The alternative of living in pain the rest of your life is not a good option. And having open back surgery that doesn't work is not a good option. Because the alternative treatments don't work. This works. That's why there's so many people out there with chronic back pain that have never been fixed, because their doctors can't fix them. We figured out how to fix it, and that's this surgery. If you want to know what the cost would be for you, fill out the free MRI review and submit your MRI, and you will get an exact cost, not an estimate. We tell everybody what their cost is before they come, and that way there's no surprises. Now, sometimes we do get surprised with finding something else that we didn't know about at the time of the Zoom call during your MRI review. Like somebody will show up with facet joint pain, like this patient, where we didn't know they had it. And the only way you know you have facet joint pain is with the physical exam. Now, a lot of times I can sort that out ahead of time on Zoom, but sometimes people show up and they have pain in clinic the day before surgery that they didn't have. They didn't have that pain when we saw them. So, back pain is interesting. It's not always the same. It fluctuates sometimes. Certain activities bring on certain pain. All right. So far, surgery is going very well. How is his anesthesia? Good. We are in the L4-5 disc on the left side. Yeah, thank you. Yeah, Dr. Berndes is saying that he's happy we're giving such good numbing medicine. The patient's heart rate isn't changing, which is a good indication that we're blocking the pain pathways during the surgery with our medicine. Now, the medicine will wear off in a few hours, and
But the heart rate is a great barometer of how the patient's doing.
uh-huh.
The anesthetic and the surgical stimulus.
Dr. Berndes is talking about how the heart rate is a great indicator of how well the patient's doing from an anesthetic standpoint. And I would completely agree with him, 100%. Today we have two surgeries for you. The next case is similar. It's a patient with herniated discs. We're going to be doing the Deuk laser disc repair on, but also the patient has piriformis syndrome. We're going to be doing a piriformis release. Now this patient, we have this disc and one more to fix. We're going to then go off air and we're going to restart with the facet treatment. He's having 3 facet joints treated on the left and 3 facet joints treated on the right. So a total of 6 facet joint rhizotomies. Rhizotomy is a great treatment for facet pain if you actually can do the rhizotomy. Rhizotomy means you're cutting a little nerve. It's called the medial branch of the dorsal ramus. Rhizotomy means to remove, get rid of. Rhis is the nerve root, and not nerve root, but the little nerve. You don't want to cut the nerve root. That would be bad. Patient wouldn't be able to move their leg. So we want to cut the pain nerve. So rhizotomy is cutting the pain nerve. Now, the typical way doctors do rhizotomy with pain management is with radiofrequency ablation. And the typical RFA treatments don't work. That's the problem. They're using a skinny little probe that doesn't kill the nerve. They want to kill the nerve, they just can't. It would be like shooting a BB gun at a bear. The bear is going to still come. You are not going to stop a bear with a BB gun. Now, they go out and sell this shooting the bear with the BB gun to everybody as, you know, it'll help. It could deter the bear, make it go the other way. But we all know shooting a bear with a BB gun isn't going to work. That bear is going to come and get you. So you better have something more than a BB gun. And that's when I realized we do have something more than a BB gun. We just don't use it. So I started using it, and we patented the technique, and it's now patented. It's called the Deuk plasma rhizotomy. And it works very well. It works 99% of the time to get rid of the back pain from the facet joint or neck pain from the facet joint. Henry, you want to show the audience the Deuk plasma rhizotomy lumbar. How does it work to get rid of facet joint pain?
Copy that.
Thanks, Henry. So you can see from our video that the facet joints are located in the back of the spine, either in the cervical, lumbar, thoracic region. They move, folks, with any kind of movement you have, and they are the second most common reason people have chronic back pain, facet joints. Facet joint pain is extremely common, and it causes stiffness in the back, as well as any kind of pain with movement, and it is extremely debilitating pain. In other words, patients have a horrible quality of life because of facet pain. We want to fix that. You have to get rid of facet pain. Now there's 3 ways to get rid of facet pain. One of them is, I would never recommend it, and that is to cut your facet joints out. That requires a massive surgery, very bloody, full of scar tissue, very painful, long recovery, and then they put a metal joint in there. And I can tell you right now, those joints never fit properly. Okay, it's a facet joint replacement system. It is garbage. They work maybe 10% of the time to get rid of pain. Okay, they don't work 90% of the time, in my experience. Now, somebody's going to get angry with me for saying it, but it's the truth. I would never recommend facet joint replacement with metal. But, of course, the companies that sell those things want you to believe that they work. So they'll try to sell it to the surgeons, and the surgeons will sell it to you. Avoid it at all costs. Do not get a facet joint replacement. Second best way to get rid of facet pain, which I used for many years and it works great, is fusion. Fuse the joints, they don't hurt anymore, okay? However, fusion is highly invasive, very dangerous, bloody. You got to take narcotic painkillers. So it's bad stuff. And today it's unnecessary. In the old days it was necessary because we didn't have the Deuk plasma rhizotomy. And so patients who came to us, hold the tube, and they had, they had facet pain, we would do an RFA, radio frequency ablation. We do like 3, 4, 5 of them. And if the patient's pain kept coming back, I would recommend a fusion for a permanent solution. And they would get it done. And the pain would go away. But it's a very painful surgery, long recovery, severely traumatic to your spine and body. Need to be on painkillers for months afterwards, after a spinal fusion, often. And there's complications like blood clots, infections, hardware failure, hardware migration. I mean, the list goes on and on and on. So I don't recommend fusion for facet pain. We developed a new technology where we go in and basically kill the pain nerve using a special probe, a wand, and it works really very, very well. Better than any other treatment. And it takes 10 minutes to do per facet. It's bloodless, there's no bleeding. And it's a permanent fix usually. So pain doesn't come back. Questions?
Yes, we have a comment and a question. First comment coming from Mixin on Up on YouTube.
Mixing on up, welcome.
Saying, watching some of your older videos talking about collateral damage has opened my eyes as to why I've had 3 discectomies on my L5 to S1. Between the tear never healing and the laminotomy done has left my spine so unstable when I go lift, that disc is taking so much of the stress.
Yep. You got it. You're right, but the good news is I can get rid of that pain most likely with this surgery you're watching right now, the laser surgery. This surgery stabilizes the spine. So a lot of people instability is severe pain in your back or the development of a neurological abnormality, which is basically weakness, numbness, tingling with normal movements and activities, normal physiological loads, okay? And this was first described by White and Punjabi, 2 doctors, one a PhD engineer and the other one a orthopedic surgeon. Look it up, White and Punjabi. They're the first to describe spinal instability, I think back in the 60s or 70s. And they published it, and that's really what spine surgeons use to define instability. Okay, pain and neurological deficit with normal loads, normal activities. So the Deuk laser disc repair, this surgery you're watching now, gets rid of the pain and gets rid of the nerve symptoms. So it basically restores stability to your spine with this procedure. You've had 3 discectomies. Could we still do it? Absolutely. I would try to avoid a fusion at all costs if I were you. And the Deuk laser disc repair, this procedure is your best chance of avoiding a spinal fusion. Okay? But these doctors, what they do is they'll just keep doing discectomies on you until you tap out. Laminectomy, discectomy, until you say, "Doc, what else is there?" and they say fusion. That's what they want. That's the end game for them. They want you to do a fusion. Okay? They want you to do a fusion. But if they say fusion in the first day, you're going to run away and go to somebody else. And they don't want to lose the business. So instead, they tell you, let's do a discectomy. And you're like, oh, that sounds good. And then you get your discectomy, and they've just drilled away holes in your spine and made your spine more unstable. Okay? They know they're doing it. They're not stupid, yet they do it. Okay? They do it because they want you coming back as a repeat customer. They want more business from you. They want you to come back and then get a second surgery and a third surgery. Oh, and they want to refer you to their buddy, the pain management doctor, so that you get shots, that you get stimulators, you get morphine pumps, you get all kinds of drugs and crap that just fill your body with stuff that's useless and doesn't work. Okay? That's the problem. So it's a broken system that rewards doctors for not fixing you. Financially rewards them. And I'm trying to fix that. I'm trying to make people aware of it. I'm the only one in the world doing that. There's nobody else doing this. Opening your eyes. And we broadcast live every week that I'm operating to try to help people understand the truth about what's happening. It's like invasion of the body snatchers all over, you know, in healthcare. And it's all being driven by greed. Okay? Anybody watch Invasion of the Body Snatchers? Oh my God, you guys are horrible. No, Invasion of the Body Snatchers from the 70s, 60s, 70s. It's a horror movie. Go watch it. Go watch the original. It's terrifying. Yeah. Anyway, done with this disc. Any other questions, Henry, or comments?
Yes, we have a question coming from Mohammed on YouTube.
Mohammed, welcome.
They ask, "Hi, doctor. I have lower back pain. Recently, I am feeling pain on my pelvic. Is this normal?"
The pelvic area, yes, it could be your sacroiliac joint. It could be your facet joints. There's a variety of causes. I'm not sure what you mean by pelvic, but the SI joint, sacroiliac joint, is the most common reason. So look it up, sacroiliac joint dysfunction, and you might see yeah, that's what you have. But if you were here, I could diagnose you and tell you what's wrong. Pelvic pain could also be lots of other things. Could be, related to your testicles, your scrotum, your epididymis, male parts. It could also be a hernia, an inguinal hernia. Some of your intestines coming through the anterior wall of your abdominal cavity. Very common for men. There's lots of reasons you could have this pelvic pain, but if it's coming from your spine, the most likely cause would be the sacroiliac joint. Write down, Henry, sacroiliac joint.
Copy that.
Dysfunction. All right, next question.
Next question. This is a comment coming from Mixing On Up, once more on YouTube, saying, "I've been avoiding the fusion like the plague.
Yeah.
So when I herniate a year or two from now, I will be coming to you."
All right, I appreciate that. I think that's a wise choice. Avoid fusion. Because fusion is only the beginning. Lay still. Shot. Yeah, take your time. Take your time. Shot. Uh-huh. Very good. Now we're going to be going into the L3-4 disc from the right side. Do you have num-num? Let's give him a little more nummy-nummy. Folks, we call the numbing medicine num-num. I'm going to make the incision. We already numbed this area up, but we numbed it again. We've lost about 5 cc's of blood, not very much. Maybe 10 at most. It's more than we normally do. Normally we lose about 1 cc, but he has some other medical issues that make him bleed a little more, and it is what it is. All right, any questions?
At this moment, no current questions.
Great. We're going to get started on the last disc. Shot. I'm leaving the guide wire, taking out the needle, placing the dilator over the guide wire to enter the disc. Thank you, Louise. That's perfect. See how nice that is? Shot. Folks, ask questions. I'm happy to answer them for you.
No current questions are appearing at this time. In the meantime, would we like to present of what is a microdiscectomy? And why
That's
people
a
should not get it at all.
Yeah. We talked about collateral damage, folks. Collateral damage is damage that the surgeon does to you and your body while they're doing surgery. Never heard of it? Well, it's a real thing. Think about it. The incision, right? If you have, say, kidney cancer, you need to have your kidney taken out, right? The incision is collateral damage. The incision is not removing cancer, but it's needed to remove the cancer. Okay? The point is, surgery always involves some type of collateral damage. In other words, damage to your body that is a necessary part of the treatment in order to achieve a surgical goal. In this surgery, we have collateral damage. The collateral damage is the skin incision and the loss of some blood, very minor. But in open surgery, collateral damage includes removing normal bones and ligaments out of your spine. It's perfect. Okay? So there's far more collateral damage that's permanent damage to your spine and body with open back surgery. You don't have any of that with the Deuk laser disc repair. Just a minimal amount of bleeding and the reason we have more bleeding here is because we were already in this disc on the other side. So remember, we did surgery on the left side at L3-4, now we're doing it on the right. So this blood you're seeing is actually coming through the disc from one side to the other. It's pretty incredible, but it always happens that way. So first time I saw it, I freaked out. I was like, oh my God, what's happening? By the way, you can see some inflammatory tissue on that piece of herniation I just took out. The reality is that you can't really do surgery without blood. Now I know they have radio surgery where they're not losing any blood, but it's not really surgery. They just call it surgery. But surgery involves making an incision. And anytime you make an incision on the human body, no matter how small it is, it's going to bleed. And some of the blood may be under the skin, you won't see it, but it's bleeding. Point is, you'll always lose blood with an incision. Okay, even small ones. So we lose blood too with the surgery, but the key is we're losing very little blood. The problem with major spine surgery is you can lose a lot of blood and actually need a transfusion. With the Deuk laser disc repair, we've never, ever had to do a transfusion, ever. As a matter of fact, we've never had to take a patient to the hospital afterwards. So it's a very safe procedure. All right, just about done. I've just pulled out a few pieces of herniation and I've got to clean the last of this tear up. And then we're going to be done with the Deuk laser disc repair. We're going to end this live stream. We're going to go to a second live stream on him where we do the Deuk plasma rhizotomy. We're going to fix his facet joints. Any questions?
No current questions. So in the meantime, let's show of what is a microdiscectomy.
Let's do it. But, you know, tertiary syphilis you can't fix with antibiotics. All right, welcome back. We were just talking about syphilis. Sorry if it makes you squeamish. Talking about the neurological complications of tertiary syphilis, which is syphilis, as some of you know, is a spirochete bacteria that infects your body, sexually transmitted. And once it gets into your body, it creates ulcers locally, but then it spreads to the bloodstream, spreads to the brain, the spinal cord, joints. It causes so many problems, and it can They call it the great masquerader because secondary and tertiary syphilis are not localized to your pelvic area or mouth. They go to other parts of your body, musculoskeletal, neurological system, cardiac system, and they cause symptoms that make the doctor go, oh, maybe you're having something else going on, and then it turns out it's syphilis. And the nice thing is syphilis is curable with just some antibiotics, right? But you got to have the diagnosis made, and doctors miss it all the time. Doctors miss things, folks. They do, and you need to be aware of that. Your safety and your life depends on doctors making the right diagnosis, because doctors have to administer treatment. You can't administer treatment on yourself. So you need a doctor who's good and figures out stuff so that you get the right treatment. Otherwise, you can die from a treatment that you shouldn't get. It's serious business. I take my oath and my responsibility very seriously. Unfortunately, a lot of doctors don't. All right, any questions?
No current questions.
We are pretty much done. I'm coming out now. I'm pulling out, and we're done with the DLDR. We are going to move on to the Deuk plasma rhizotomy. We will start a new stream. So since there's no questions, Henry, why don't you go ahead. I'm going to finish taking this little piece of herniation while you switch over to the next live stream.
Copy that.